we are really at a very interesting point, and this is a difficult talk to give because we are in Ted Cruz's state, and we've got to talk about health care reform. So we're just going to jump right in and do it, right? Because regardless of his ego, the thing is going to happen January 1st, 2014, and we're going to presume that that's true. And if somehow Ted gets this thing off the rails, I'll come give a new talk next year. But for right now, we're going to assume that the Affordable Care Act is going to take effect January the 1st. And based on that assumption, we have to integrate into the healthcare marketplace, and we have to be part of that. So the notion of this talk is that 30,000-foot start, and then we'll get to some very concrete specifics at the end of things that we believe need to be included in an electronic medical record from EMS to keep us funded going forward. So that's really kind of where we're going. Some disclosures: I have no conflict of interest. Most of the items we're going to talk about are not FDA approved. The views expressed don't represent the official opinion of Wake EMS or ESO. Needless to say, these views therefore are well-reasoned, cogent, and universally applicable. And as Jeff Goodloe, the medical director from Tulsa, would say, I don't have a conflict now, but if you want a potential conflict, meet me in the back of the room after this talk, and I'll be happy to take that on. So we'll start with Scripture. And here's the reason for that. We have to take a faith-based approach to healthcare reform. And I'm going to try to be as agnostic as I can about healthcare reform. Here's the deal, though. And then this is where we're going to kind of put the bounds on this thing. We as a country, decided a long time ago that we were not going to leave people on the side of the road. We made that decision. They have not made that decision in South Africa. If you don't have your little card and you wreck your car and you're on the side of the road, they'll just leave you there because you hadn't paid. Fine, that's a model. If we want to use that model, that's okay. But we're not using that model here. Fast forward to now, we are trying to incorporate everybody in a very short period of time. And there is no roadmap. We've got to go by faith. And the faith of the thing is, when we put everybody in the game, it's going to get better. So we're going to talk about the faith-based approach because that has to be there. Having said that, there are some mileposts that will help us. And the first of those is from Dr. Brenner, who was ethical, who was very intelligent, who was patient-centered, who was data-driven, so needless to say, was fired by the federal government. And this director of CMS gave us the best approach. One of the things that I think is easy to walk away with from the talk I'm getting ready to give is that Myers stood up there and talked about money. We are not talking directly about money. We are talking about improving health care. And oh, by the way, when you do health care better, it costs less. That's the side effect. That's not the driver. The driver of what we're trying to do is improve health care. And just take one example. The familiar faces that we see, that's the new politically correct term for frequent flyers, right? The familiar faces. The familiar faces that we all see in our system rotate in and out of the system because we are not caring for them very well. It is our problem as much as it is their problem. We have to improve the care for those people. And oh, by the way, when you do that, it's cheaper. But you see where we're going. We've got to have the data to know who those people are, to know what their health care plan is, to know how to fix them. But it's not money driven. That is the side effect of where we're going. So this is Obama's view. And as you know, the gentleman there to his side leaned over and very publicly talked about what a big deal this is, right when the health care bill was signed. So from Obama's perspective, what do we see? We see a system that brings everybody in. And as I said, I'm going to try to be as agnostic as possible about the politics of this, but we have to talk about it a little bit because it's the elephant in the room. The notion is everybody's in. And I love the far right's opposition to Obamacare. This plan came off the shelf at the Heritage Institute. This is the far right plan against Hillary Care 15 years ago. Verbatim. So from his perspective, we are bringing things in, and we're going to bring everybody in the tent, and we're going to improve health care. So for him, that's the way you look at it. From Karl Rove's perspective, it's all taxes. So the other side of the argument is this is not free. And the part that we, I think, all have to embrace as we go forward is this has always been our money. But now it's very obvious it's our money. And here's an example, just one example of how I think data is going to make our lives better. I was working in the ED last Saturday. Patient came in from an assisted living facility that was 3 hospital distances away, past 3 other hospital districts to come see us. What happened? Her PICC line had a hole in it. She was on IV antibiotics week 3 of 6 for a presumed osteomyelitis, and she got vancomycin every morning. And when they put it in that morning, it leaked. So what did they do? They put her in an ambulance, called 911, put her in a 911 ambulance, brought her to the ED for me to do what? Take an alcohol swab, loosen the adherent part of the PICC line, pull it out, put a Band-Aid on it, start a peripheral IV, and send her back. That is our money. That's not somebody else's money. That's our money. That's Medicare dollars that paid for that level of care. And we, as the EMS system, actively participated in wasting all of our money. So I'm not opposed to Karl Rove's view. It is all our money, and we ought to be better stewards of it. And I think we can be. No matter what, it is complicated. And the notion that we're trying to get the patient and the healthcare provider, who are in the circles on the ends of this chart, somehow closer together is the complicated piece. And that is where a true data exchange, where we incorporate the members of the community, helps us. That's where we get to the place we want to be. So why is it EMS? Why should we be the ones? Because we do this all the time. Everybody else is scared. We calm the waters all the time. So we should. And my favorite part is when you go to talk to the feds about this deal, right, and you come into them and you say, we need to talk about reforming EMS. And what do they say? It's 1% of the CMS dollars. We don't care. It's 1% of the dollars. We don't care. It is our job to demonstrate that, yes, that is the direct cost to CMS. But what we do with that patient once they call us creates a huge ripple effect downstream. And whether we take that woman with the hole in her PICC line and just go in there and change her IV ourselves and do nothing, or we generate an ED bill, a hospital bill, a transport bill, and all the rest, is up to us. And if we have true data exchange, then we don't have to do silly stuff like bring somebody in on a Saturday afternoon because they have a hole in their PICC line. There are ways that we can fix that problem. And we sit at the fulcrum, if you will, where we can do that. So this is the part that we all have to face. And I've told this story before, but my mother and father are the greatest example of politics in the world. Dad gave money to Jesse Helms when he was in the Senate in North Carolina at an incredibly high rate. And partway through dinner one day, Mom looked up and said, you know, you have given more money to the ACLU than anybody in North Carolina. And Dad said, what in the world are you talking about? And she said, well, I went through your checkbook, and every dollar you wrote to Jesse Helms, I wrote $1 to the ACLU. So she said, there's got to be balance in the world. It is that two-sided problem that we all are dealing with. This says that 1 out of every $4 in the United States in the next 10 years will be spent on health care. 1 out of every $4 of our gross domestic product. So people hate the federal government, but they love their Medicare. And Medicare is 25%, soon to be, of the federal government. So it's very difficult to get our brains around this notion that we've got to change. But we have to, and we can say it anti-feds, we can do whatever we want, but the bottom line is something's got to give, because this is not sustainable. You can mess with all the other spending. You can see mandatory programs, discretionary spending, all the rest, it doesn't matter. If you don't fix Medicare, it's over. So we've got to do something, and I think we're getting ready to do it. Okay, I stole this one from Ed Rock. I love this slide. Heaven forbid we actually have to operate like a business. We actually have to think about a customer, an outcome, and a value proposition, as opposed to you call, we haul, that's all. And that notion is only possible when we have all of the data, when we have a community-wide healthcare data exchange. So that's where we're headed. All right. This is what's happened to us. And as we know, those things that don't matter from an emergent perspective are increasing, And those things that are non-emergencies are staying the same or decreasing. So your general medical illness calls are going up. We are all in the healthcare business to some degree or another, and we can navigate the system pretty well. But we must stop, I think, asking ourselves why someone calls 911. If you are a standard citizen of the United States that has no relation to the healthcare industry at all, why would you call any other number? We can have help to you in less than 15 minutes, some places 8 minutes to 59 seconds if you believe that matters. And they're there reliably, and you don't have to pay, and they'll navigate you straight through the healthcare system. Why would you call any other number? So from our perspective, I think our next approach is we need to stop being frustrated by this graph and embrace it and change our practice pattern so that we truly are providing health care for the entirety of the population, not just the ones that call 911 for the reason. The triple aim is the thing, right? This is how we are going to measure ourselves going forward. And if you think about a healthcare data exchange and the elements you need in it and hang them on these three things, it makes perfect sense. So the first thing is the patient has to be satisfied. And we're going to say this a couple of three times, but one of the things we want to challenge ESO to do is to incorporate the patient experience, patient satisfaction in the patient care report. We see this notion of hospitals are getting paid because the patients are happy. If we, as EMS, really piss them off before they get to the hospital's behind the 8 ball before they get started. The patient doesn't separate those two experiences. They see that as the overall healthcare experience. We also need to evaluate how the patients feel about what we're doing. As we go forward, we're going to show some examples. We're talking about changing the way we do business. And what we want to know is, how do the patients feel about that? And there are external ways, there's all these other surveys, but the best way is for the patient satisfaction survey to come right out of the ESO or whoever your healthcare product is. Everybody's got an email account, right? The homeless population goes to the library to get their benefits with an email account. So it's very easy to figure out how we're going to get this result back. It just needs to be part of it. The patient experience is important. Improving the health of populations is the next bit. All of us, hopefully, can report our cardiac arrest survival rate, right? We know that number, and that is a whopping 0.085 or 0.85% of our run volume. So for 99% of our patients, that doesn't count. But in the absence of a data exchange, I can't tell you how they did. How did my CHF patient do? All down the list, you've got to have that integrated. And then finally, and it is in order on purpose, we talk about cost. And we talk about the proposition of a value equation to the patient. And for that, we'll talk about in a little bit, there has to be a community-based mechanism when I enter that patient in the ESO that will tell me what options are available to them. That's the second challenge for Dilley. The first is patient satisfaction. The second is I put in everything. I know their insurance status, I know their age, I know all this other stuff. What is available today for that patient besides an emergency department? And that has to populate so that we know that. We'll go into more detail of that in just a little bit. So here's the issue. 5 to 10% of the population calls 911 for an ambulance every year. In Wake County, it's 8%. We're right smack in the middle of the range. They call 911, 5 to 10% of the population every year for something. Depending on which articles you read, somewhere between 11 and 52% of these patients don't need an ambulance. And I think we all can agree with that number. And we're probably more on the 50% than the 11% study if we are honest with ourselves. But our current practices, all of our education curricula, all of our reimbursement streams take us to one solution: hospital emergency department. That is the only solution today, and we're going to propose that this needs to go away. There's a lot of movement at the federal level. It hasn't moved as far as maybe we want it to, but there's a lot of movement there. Us living in the Department of Transportation is causing trouble for us. CMS therefore sees us as a transportation benefit and not as a care benefit. That's the first federal thing that we've got to change, that attitude of the benefit to the beneficiary of Medicare for EMS is transportation. We've got to change that vocabulary to care, navigation, mobile integrated health care, whatever we want to call it, but we've got to get away from the you call, we haul, that's all perspective. So why is this so? Well, we were created for interstate highway accidents. And now up to 10% of the population is calling us, and we treat each one of them as if they have wrecked their car on the interstate. And that's got to stop. We are much more mobile healthcare than we are responding to traffic accidents. We saw the slide. Those numbers are going down. So we've got to change that mindset, and data is what's going to get us there. So this is where we are today. To the left, patient calls, we go, and we take them to the hospital. The goal of a mobile integrated healthcare practice is that we can navigate the patient through that system. And to be able to do that and do that well, we have to have the data from the community. And we'll go into some specific examples in just a little bit. But the notion that the individual paramedic on the back of a napkin can do this is fallacy, right? It has to be at a community-wide, integrated data network, and we'll talk about what those look like in just a little bit. So I want to thank all the people that have helped us. The most important thing I want to talk about is the last one on this list is the North Carolina Office of EMS. Other states have run into regulatory issues. They've run into other things that you cannot do what we're getting ready to show that we're doing. And the North Carolina Office of EMS took a different approach. And their approach was, we are going to support this. We are going to enable this in every way that we can. We're going to promote this at our statewide conferences. And so we really, I just cannot say enough about the support from the North Carolina Office of EMS for the things we're getting ready to talk about. All right, so this is the only ESO bad slide. I had to take 2 of them out since Dylan made the promise, but I couldn't remove this one. Don't worry, madam, we don't actually store your data in the cloud. We keep it in a box under the bed. When we have asked for some data, and data are plural, by the way. I'm going to just a slight little rant. Whenever you type this in, so I'm not going to name the healthcare vendor we got at our hospital, but they have this thing when the little hourglass comes up, you know, because it's loading, it says data is loading, and the top of my head wants to fly off. We pay you people. You are the data people. Datum is singular. Data are plural. Data are loading. Data is not loading. Anyway, data are plural. So the notion that we cannot see transparently all of the data that's in the system is crazy. And it should not be in a box under the bed. And so we are having this discussion back and forth that the data have populated all of these tables. And behind the curtain, Billy and his folks can look at all of that, but when our providers log in, they can't see it. So we've got to get it out from under the bed. That's the point of that part. And we're getting there. I know we're getting there, but I won't be asked back to speak next year. All right. So we've already talked about this, but this is where we want to go. Right? We need to be at this point going forward. Reduce, redirect, and so forth. This is the ultimate goal for us to integrate it in health. The other way of looking at this is that we have treated everything as if it is a time-critical emergency, and we have forgotten that experience also counts. So as we talk about a mobile integrated healthcare practice, we're going to have ultra-time critical events. We're going to respond to those as we do today, and we're going to take care of those emergencies. But as we talk about alternative destinations, alternative transportation, not taking everybody to the ED, I have 1,500 first responders at the BLS level. There is no way for them to have sufficient experience to make those decisions. So as we go into mobile integrated healthcare practice, we've got to think outside that framework. We've got to talk about advanced practice paramedics, community paramedics. We've got to talk about our case managers at the hospital, home health, the whole 9 yards. We need to incorporate all of that on the experience side. And this is just, in my mind, the best way of looking at that. Things off to the left are protocolizable, treating anaphylaxis, treating cardiac arrest, bad respiratory distress, et cetera, et cetera, et cetera. As you come across to the right, it is not as protocolizable. It requires judgment. And to have the judgment, you have to have the experience. And it may be a paramedic, it may be a community health worker, it may be a home health provider, who knows? But somebody that's got the experience to help make these decisions. Okay, so let's talk first about the most difficult thing that we do. When we step off into this mobile integrated healthcare practice, the first knee-jerk reaction is to say, oh, finally, I don't have to haul all those people to the hospital. And so the notion is, I'm just going to decline them all. That's great. Finally, it's done. I'm tired of hauling these people around. I'm just going to leave them on the scene. And if we do that, then we lose our ability to monitor the patients, if you will. And this is the first integrated part. So we'll talk about that. Doing the same thing over and over again, expecting different results, we know that's the definition of insanity. So how are things working today with our integrated healthcare practice, our HDE, and our follow-up of non-transports? Well, we had to go and create an entirely separate database to follow our refusals. Now, going forward, hopefully we don't have to do that. But today, the refusals are in an entirely separate database. We have a commitment, and so far we're in about the 12th or 13th month of this, where we are calling every single refusal. So every patient that doesn't go to the hospital, we attempt to follow up. Now, do we get most of them? No. But we are attempting to follow every one of them up. And this is how that works. These are the questions we ask. Are you still experiencing the problem related to your call? Do you need medical assistance now? Were we prompt and were we nice? That's really what we ask. And everybody knows that we're going to ask these questions. So how's your problem? What's going on with it? How can we get you better? That's the way that we want that to go. But tomorrow needs to be different than that. It doesn't need to be a medic in a dark room with a handmade database that is separate from the patient care report that's talking about what happened to our non-transports. Tomorrow it needs to look like this. It needs to be just like the doctor's office. So that when we follow up that patient, not only are we seeing what happened on our call, we are seeing that patient's medical record. We are seeing what happened at the hospital. We are integrated with their primary care physician's office. And this is doable today. One of our healthcare systems actually has done this as it relates to pediatric patients, such that if you are a patient of this particular pediatric group, when you go in the pediatric ED and they register you in, it automatically flags and pulls your previous note from the doctor's office, populates it there, and then as they leave, the ER note pushes out back to that doctor's office. This is simple. This can be done. And so us sitting in a little closet, following up our little patients didn't go to the hospital, and then putting it in our own little database is silliness. This needs to be, we went to see you, you didn't go to the hospital, where did you go, how can we get you there, and what options are available to you? So the other issue that is obviously very important to us is integrating images, and particularly EKGs and results. When we go to so-and-so's house and they've got a left bundle branch block, we don't know if it's new or old. In 2013, that's silly. We could take our iPhone, or sorry, can't endorse a product, our smartphone, and snap a picture of an EKG and send it easier than we can integrate it in the healthcare system today, and that doesn't make any sense. From the patient's perspective, they have no patience for this anymore, nor should they. We ought to know if their EKG is new or old and all the rest. And then this follow-up survey and request for well-check visit. That, to me, is the ultimate part of this component of integrating healthcare, such that when we call that patient and they say, you know, I'm doing fine today, but my prescription's running out tomorrow, whatever these simple, low-hanging fruit pieces could be, they need to be integrated so that it flags and we prevent that call that otherwise would happen the next day. And integrating that into the healthcare record is not complicated, and that's certainly what we should do. Alternative destinations, that's the next thought process. So we got those that we didn't transport. What about those we can take somewhere besides the emergency department? And this notion that people call 911 because they want to go to the hospital, we've got to dissuade ourselves, right? They call 911 because they want help. They want navigation, and we need to be able to offer that to them. So today we have the well person check, which you may have seen, and then this is just, we do a quick little vital signs check. Everything checks out okay. Then we go for patients with primary mental health and substance abuse issues and screen them. And we screen them with a paper-based form. How silly is that? Right? This needs to be incorporated into the healthcare record. So we know what the things are, all the boxes, so forth and so on. And this has worked well. We've saved transport money. It's safe. We've discussed this before. I just highlight that to say that this works and this can be done. But that's where we are today. The next piece is incorporating into the medical record with the primary care physician. And for us today, to do what the Falls and Assisted Living Program, and I'll go over that briefly for those of you that aren't familiar with it. For us to incorporate with a primary care physician, we had to go to the primary care physician and let them give us access to their medical record, rather than having it integrated with the EMS report. So we are duplicating efforts, and we have non-integration of the data today. This particular program, someone's found down in an assisted living facility, they call 911, the advanced practice paramedic goes and operates on these 3 tiers. One of the tiers is obvious. They're bleeding, they've got an angulated fracture, they had true syncope, so forth, they go to the hospital. The other two tiers, though, are those that are not obviously ill or injured, and they remain in the facility after we contact their primary care physician. And then we go and log into this cumbersome thing and put all that data in there, and then when we want to figure out what happened with them, we go back in the office and re-log in to the primary care physician's medical record and pull that data manually. Hopefully in the future that's not the case. Just FYI, we now have encountered 71 folks. We've left half, so 35-ish, have been left behind, none of whom have had a bad outcome. But the only way I can tell you that is after this manual data pull. And what we want to have is when I log into ESO, here's the patients that fell yesterday, and here's where they went, here's what their primary care physician found, here's the ones that bounced to the ED without all this manual back and forth. So we know that that integration is possible, and that's something that we probably want to do. So the future state for alternative destinations looks like this. Real-time availability of alternative sites. So this, to me, is the holy grail of where we want to be. That when we log in to ESO in the Wake County community, they have every primary care physician's office, they have who's eligible for what benefits, and they know who's available right now. So in real time, just like at the airport, we're delayed, we're canceled, we're boarding, we're whatever, we can move those patients to a real-time alternative destination based on pre-established community standards and criteria. And this is clearly doable. We do this today with a 3-ring binder where the poor advanced practice paramedic is flipping through the thing trying to figure out whose benefits go on which flow chart so we can decide which clinic to place them in tomorrow. That should be pre-populated for every patient that we encounter so that the ED becomes the destination of choice when we need it, not the default for everybody. And the only way to get there is to have this real-time patient navigation. There also needs to be this financial screen, and this is where we cross over into the world of healthcare reform and get in danger. But in the absence of that, we cannot navigate our patients. So today, we have medical homes for every single Medicaid enrollee in North Carolina. Now, we did not take the Medicaid expansion, so I don't know what's going to happen January the 1st, but it ain't going to be pretty. But today, if we could have this integrated, then what would happen is we would type in, we put in their Medicare number or their Medicaid number, and it would say their medical home is Rock Quarry Road Family Medicine. They have an appointment available at 10:15. Send them. But what we have today is get on the phone and try to figure out where their medical home is, because I don't know about all of your patients, but ours don't remember. And they don't know what their medical home is, and so we have to start hunting, and then we get tired of that, and so what do? We reflexively go to the ED. Tomorrow, it needs to be this type of navigation, 360 reporting of outcomes. The last thing I want to talk about on this slide. We not only need to know how they did while they were with us, we need to know how they did while they were with everybody else. And so this notion that we gave aspirin, good for us. But what we really want to know is, did they go home with CHF, or did they recover from their MI without CHF? That's what we really want to know, the value proposition to the patient. This is doable, we just have to get there. I was having a conversation just before we started with folks about the HIPAA concern, and let's just go ahead and get that out of the way now, right? There is no HIPAA concern about this. Hospital attorneys that want to make this a HIPAA concern are trying to hide something about their healthcare system. Right? I mean, let's just be honest. That's really what the issue is. So to put the data back and forth is not a HIPAA concern, and we should be fine and let that go. Okay. Now we're into what I consider the most important part of the future of healthcare, which is it is no longer okay to treat them well clinically and piss them off. Historically, we are paid for what we do. We are paid for transportation if you're EMS. We are paid for doing the cath if you're a cardiologist. We're paid for all this other stuff. The future of healthcare is different than that. The future of healthcare says, what was the patient's experience? And how do we improve the overall patient's experience? And here's the interesting part. When we first started alternative destinations in our system, we were talking to folks. They said, you're going to make the patients mad because you're not taking them to the hospital. We created this perception amongst ourselves that patients want to go to hospitals. What we have found is that patients don't want to go to the hospital. As a matter of fact, if you can keep them out of the hospital, they are much happier by and large. Our Falls and Assisted Living Facility program, where these patients, every time they were found on the ground, were reflexively going to the ED, when we talk to the patients, those that have capacity, they don't want to go to the hospital. They never wanted to go. When you talk to the families, they didn't want them to go to the hospital. When you talk to the primary care physician, they didn't want them to go to the hospital. When you talk to me, the receiving ED doc, I didn't want to see him. So why are we doing this? Right? I mean, you get to this point of it's just lunacy that we're continuing down this path. And this is what I call, anybody here from Omaha? Okay, good. I call this the Omaha problem. And the Omaha problem meaning that there's somebody in the risk creation department, because it's not risk management, they create risk where it doesn't exist. So in the risk creation department in Omaha that owns these, conglomerates of healthcare systems and assisted living facilities that says, if mama found in floor, call 911 and force her to hospital. For what purpose, nobody knows. We had one that we actually looked at 6 times in 7 weeks. 6 times in 7 weeks to 4 different hospitals for falls. She had, 6 times 4, she had 13 CT scans. She had full lab values on every single visit. She had a full year analysis on every single visit. She had 0 chief complaints, and there was nothing found on any of those studies. But none of the hospitals were talking to one another. None of them took the time to pick up the phone and say, did you scan Aunt Myrtle's head last week? Yeah. What did it look like? It was fine. And then, here's the kicker. We talked to her family, and we said, if they had found something on that head CT, if there had been a bleed, would you have consented to surgery? And they said, absolutely not. Mama's not going to the OR ever. That's our money, right? That is all of our money, and we wasted it on somebody that didn't want it. Now, if you take that out of context, all of a sudden we become a death panel, right? That's where that comes from. Oh my God, that's a death panel. No, it's not a death panel. It is talking to people and allowing them to operate with their own autonomy. That's all it is. What do you really want? As opposed to us projecting what we think they want. So how does that integrate with a healthcare data exchange? Well, when I log into Aunt Myrtle's chart, when I get to the assisted living facility, and we have it pop up that says, Aunt Myrtle's family doesn't want her to go anywhere, that's helpful information. Because today, what do I have? I have the nurse that was hired yesterday that knows nothing about Aunt Myrtle, right? They never know anything about him. They've never seen him before that morning, right? That's always the case. And you get there, and she says, you got to go to the hospital. And then we become complicit in kidnapping. So the notion that customer service is this foreign thing that has nothing to do with data exchange is actually nothing's further from the truth. We have to incorporate what the patient wants into our record so that at the time of their encounter, we can do what they want to do. The same thing is true with all end-of-life decisions. Beeson's done a great job with keeping people enrolled, if you will, in hospice. I think the euphemisms now, they either graduate, I think that's the end of hospice is graduation, I think. But this notion, as Beeson's word, this notion that we are the exit button for all healthcare plans. And that's really what we have become in a lot of senses, right? If the family is standing there, they don't want any of this done. But when they're not there, and somebody else wants to manage their risk, they slap the button and let us go. And take patients to hospitals don't need to be there. So I got a phone call the other night, same notion, right? You get the phone call the other night, it is they are in the nursing home, they have the patient, everybody's screaming there's a DNR, and nobody can find it. In 2013, we are going to resuscitate people because we can't find a piece of paper? Seriously? Healthcare data exchange prevents that problem. Because when you log in, there it is, the golden ticket, the pink ticket, whatever color it is in your state, it is right there for you to see. And you know what they want to do. And it's not a death panel. So, this has been our historical approach. We have not focused on customer service. As a matter of fact, many of our providers, if you talk to them, hold it as a badge of honor that they were not particularly nice to people who needlessly called 911. We're going to show them, by God. I have always been fascinated by that approach. Has it ever worked? We have people that, there's 7 There are now 71 patients out of our 1 million that have called us more than 4 times in a rolling 30 days. So there's 70-ish folks that hit the button quite a bit. And we can be sweet and kind, or we can be mean and rude, and it's not going to change the number of times they call 911 a bit. So integrating, having a plan for them, that changes the number of times they call 911. But changing their customer service does not. So this, I think, is good customer service, right? You do not have to go very far at all to get your beer. That guy's right there, ready, willing, and able. 911 is the same thing to the community. We should be the best customer service out there because all they have to do is pick up the phone and hit us and we're there. Great customer service. A lot better than, sitting around for the 2-minute thing. So this, in my mind, is bad customer service. And there's the first 911 call was made. I don't believe it was made on a red phone. Is that bizarre? Anyway. They claim it's the first 911 call was made on that phone. And we give them one item on the menu. And those folks are not receiving good customer service. They're receiving, you fit in our paradigm, not we do for you. The best customer service looks like this. It is assistance at the next exit. And to provide that assistance at the next exit, we have to know what options are available to that patient. And to know what options are available, we have to get ESO integrated into every bit of that community so that we have that full menu right now when we encounter that patient, not 30 minutes from now, not when we get to the hospital and the game's already over. So the challenge then is to do that. So this is the data in our future. And this is where I hope that we can end up with our good friends at ESO. Real-time integration for clinical decisions. And this includes what a lot of people have already talked about, which is the enhanced decision-making tool where you put in their age and their risk factors and all that, and it gives you a treatment plan. Well, that's fine. That's water under the bridge. We've already talked about those kinds of things. What we need to add is program eligibility. We need to add care availability, that real-time navigation. Who's holding me an appointment right now to see this patient today? And it needs to pop up just like you're at the airport. Existing medical records. The notion that we cannot look at the previous visit while we're sitting at the patient's bedside's got to go away. That we've got to make that part of who we are and what we do. And then prevention directives. The notion that while I'm here and I've done all this other stuff, the flag needs to come up and say, oh, by the way, you're in somebody's home that's 70 years old. Is their falls checklist in here? Have we checked their home for falls? Have we made sure that their medications are done? Is their scale right? All of that other stuff. So that it is a patient-centered approach that integrates the data for their entire care plan. And that should be there every time we log in. Customer service. We have to be able to track this. And we need to be able to track it by patient, by provider, by shift, by time of day. I'm sure that it only happens in Wake County, but the number of refusals, declinations, and all the rest change within the last half hour of any given shift. Right? I mean, that's just human nature. We need to be able to track that and track that patient experience and say, was this okay with you? I mean, patients may say it's fine. What's interesting to me is we've said this all along, right? You can hold grandma's hand and give her the worst care in the world and she'll never complain. Right? She can die and she'll never complain. As we enter into this realm of patient-centered experience as it relates to reimbursement, it will be interesting to see how they slice that pie. At the moment, it's about a third. Right? About a third of your reimbursement bonus is going to be tied to the patient experience. And I think we're getting smart enough not to allow pain to be a big part of that. The notion that you cannot go to any of the water treatment plants and not get high on hydromorphone is true, right? We got the first press gaining score, came back and said, particularly to me, you are not treating pain very well, Dr. Myers. People are leaving mad because they're not getting their pain pills. So what happens is we create our own problem. And so now everybody wants the press gaining score to be good, so they're handing it out like it's candy. So as we go forward, if we can integrate the patient experience, the provider experience with the actual medical record, then our opportunity not to create that exists. Because we can look at the individual patient experience. Rather than your patients 20% look good or 30% look good or are happy, we want to know the individual patient, what their satisfaction score was, so that we can follow up and make sure that we are not creating this unintended consequence of handing out Percocet like it's candy. And then finally, we've got to look at finance. We will have, I hope, clinical performance indicators. If we as EMS do not get clinical performance indicators as part of our payment structure, then they have yet to incorporate us into the healthcare system. They are still looking at us as a transportation benefit. So embrace it. And the beauty of where we are today with the records that are available is we can define what those clinical performance indicators need to be. They're not defined today, and if we bring forward a real list, they will embrace it. And we know what they are, right? Aspirin for chest pain, 12-lead interpretation, did we go to the right hospital, STEMI bundle done, next. Right? We know what those things need to be, we just need to be the ones that incorporate them. And the last bit, and this part will not happen by December 31st of this year, all the rest will, right? But the last part is the cost of the treatment option. At some point going forward, our patients are going to become consumers rather than benefit recipients. And that is an overarching philosophical thing, but today, healthcare is viewed as a benefit. So if I'm an employee and I have a benefit, I'm going to use my benefit because that's part of my employment, as opposed to I'm a consumer of this. So going forward, we are going to have the little dollar signs, kind of like we have on the prescriptions today. Most of your, if you work in a hospital, when I log on and I'm getting ready to write a prescription, it will tell me with little dollar signs, $1, $2, $3, or $4 signs, which is the most expensive of the options that I have for my consumer. The consumer in the field is going to know the same thing. What if I decide to go to my primary care doctor? How much does that cost me? What if I go to the ED? How much does that cost me? What are the outcomes? That type of decision tree is down the road, 3 to 4 years, but that's where we need to be. So that not only can we tell you what your options are, not only can we tell you what your outcomes are going to be, we can tell you how much it's going to cost you. And then you can start making decisions based on that as a consumer. So in my mind, these are the 3 biggest things that have to occur for real-time healthcare data exchange to work. You have to have integration for clinical decision, you have to have customer satisfaction, and we have to talk about dollars. And with that, I will stop and take any questions or comments that you may have. Yes, sir. Okay, so the question is, what are we doing about the readmission 30-day cycle problem? First of all, we just got the first true evaluation of that for our community about 60 days ago, give or take. Found some fascinating things with that, and this is the challenge, and this is where the exchange across communities is going to matter. The hospital where I work, we receive patients from 19 counties. Those patients, the community hospital, the critical access hospital, wants those patients admitted. So they come in for their initial STEMI problem, what have you, they get their cath and all the rest, and then they go back, and then they go to the ED 3, 4, 5 days later in the community hospital in the county away from us, and that still dings the mothership. So the incentives are not aligned. The community hospital wants the admission because they want the money, because they get paid full freight. And then the big house gets kind of dinged with that. So whatever approach we take, it cannot be community focused. It's got to be broader. It has to be catchment focused, whatever that needs to be. We have approached the hospitals about CHF, and Beeson's has a different experience than us. Our CHF nurses at the 2 main receiving hospitals are so aggressive that there was nothing we could offer them. I mean, they literally have the scales and the weights and the person going out. I mean, there was nothing that we could offer to prevent that readmission. So where we are finding benefit is not on the prevention of a readmission, it is on the get out of the hospital faster. So, for example, the patient in the ED that needs blood glucose checks every 3 or 4 hours because they took too much glucophage, there we're seeing some movement. But in our community, the readmission bit, the hospitals had already spent a boatload of money, and there wasn't anything for us to do. And I think that goes back to the overarching theme of mobile integrated healthcare, which is do your community needs assessment and figure out what gaps that exist in your particular community. Other communities, there's a big gap there that EMS can fill. But in our community, we just do a liaison with the CHF follow-up nurse. Probably 3 or 4 times a year, they call us to say, we've got somebody that we can't get to, will you go? And we do that, but it's very rare. They're just so robust, they don't need it. Other questions? Yes, sir. Right, so the question is, how do we integrate this not only with the healthcare system, but also social services and the rest? In our community, and in most communities, I think, there somebody is in charge of trying to reduce Medicaid expense. For us, it's called the Community Care Collaborative. I think that's a kind of a common term across the country, but somebody in every community is responsible for that. What they have done is they've already got the list, they've already got the menu, and they pull people in to sit around the table. So once a month, we sit around the table with EMS, case management, social work, the pain control people, the medical home people from Medicaid, and we run the list. And what was interesting is this really has been up and running 6 or 8 months. Every month, we were sporadic before that. We all brought our our familiar faces list, and the familiar faces list was identical. Ours, social work, jail, hospital, it's all the same folks. And so we were able then to really bring them together. But the key to that is figure out who's already having that meeting and add yourself to it. And somebody's having it. I guarantee you somebody's having it. Yes, sir.
Given our current status of employment place with varying levels of education and years of experience, how many, just on the paramedic level, how many paramedics can function in this new integrated model today? And how much re-education or additional education is it going to take to get our workforce up to this standard?
Whew! Time to go. It's a complicated question. So the question, for those who didn't hear, the question relates to, we've got multiple layers of education in the field today. How do we incorporate them into this mobile integrated healthcare practice tomorrow, right? The way we did it, and I think the way that works best all over, is we started with the community needs assessment. And for us, we had a mental health crisis in North Carolina. And it's still there today, but it was even worse when we started the program. So we knew that patients were going to EDs. There are a little over 10 million people in North Carolina. There are 3 state mental health hospitals that are still operating. So everybody else was pushed out in the community. They were overloading the EDs. So we started with, we want to make sure that our providers are very good at mitigating mental health crisis. So we designed a curriculum. We brought them in. We piggybacked onto a law enforcement curriculum that already existed and got them certified through that program as well, and then put them in the clinics, in the mental health institution, so they could see what services were available at all the different places. That education then allows them to do this alternative destination stuff for mental health and substance abuse. That was the need in our community, and then we designed a program through the community college to do that. What we're seeing is that there's some common things throughout that everybody kind of needs, and then there is this notion of the community needs assessment. So what I encourage everybody to do is start with what is it I'm trying to do? What does the community need? And then design a curriculum. And there's a lot of them out there that you can pull from, and there's some commonalities, but then the curriculum will be yours. Just to give you an idea, ours was about 240 hours of direct contact and about 240 hours of clinical observation, give or take. We did it through the community college, so there was no cost to us other than developing the curriculum and staff time, but the people in the seats were students. They were not employees at the time they were there. So that's one way to get at it, but there are other curriculums. But that's how I would do it. Yes?
So we have the technology to integrate. How do we get the hospitals to really step up and want to do that? With all of the things that are going on, and we have a hospital very interested that they're dealing with a switch over to their new data system. So their IT department wasn't.
So the question is, how do you get the hospitals to buy in, right, and get them to commit staff time? That was probably the biggest thing that we had to overcome, and I've got to give a shout out to Benny Collins, wherever he is, because you got to have a champion from the EMS side, and then you've just got to keep at them. And so, we are now in the 3rd year of a 6-month project, right? I mean, that's the way those things go. It is to the hospital's benefit once you can let them see a couple of things. The first is we share address and insurance information. So as the data exchange goes across, we get better billing, and so do they, right? Because we have a double check, and it's a better way to get money for them. The other thing is, and we were talking to somebody at the other table, the high dollar patients often benefit from an EMS record being present. 2 reasons for that. The first is, thank God, all of our accrediting bodies. So when the Society for Chest Pain Centers come, they literally randomly pick charts and say, show me the EMS run report. And if that run report's not there, then you get dinged from the Society of Chest Pain Centers. So all of your accrediting bodies have incorporated that, trauma centers and all the rest. So if you have a specialty designation and we have a data exchange, then you're not going to have missing run reports for accredited time. But at the individual patient level, you also like to have them because I'll take STEMI as an example, going straight to the cath lab, we don't get an EKG in the ED. We just go straight to the cath lab. Well, if you don't have a diagnostic EKG in that chart before you do the cath, you don't get paid. So the ability to move those records across so that you know you're getting paid individually and you're getting accredited and you're getting better billing information are the three ways that we try it. The part that I wish I had done more, and lesson learned, my partners in my emergency medicine practice love this. Because when they go to see the patient, literally they scroll up, there's the nurse's vital signs, and then right underneath that is the EMS run report integrated into that chart. So they don't have to go looking for it, they don't have to say I never saw it, all that, and they love it. So getting physician buy-in to say you're not going to be dinged by the attorney because you never read the EMS run report that was technically available is the way I wish I'd pushed it more from that perspective to start with. I just didn't think of it. Well, we're supposed to finish at 10:15. Is anybody mad if we finish at 10:05? All right, I'll hang out for questions, and we're back here after a break at 10:40-ish, something like that?
Yes, we have there's going to be a 30-minute break, well, more than a 30-minute break. So at 10:45, please come back here for David Gibbett.